Good morning, and we'll start what is the last CGR for this semester. And for this presentation, the Department of Pediatric Surgical Specialty, Super Specialty, will present esophageal atresia, what is the spectrum and the prognosis, and they will give their experience. So I request Dr. Vijay Upadhyay to start the proceedings.
Thank you, sir. Good morning to all. First, I will welcome all of you for our CGR, and I am representing my department for this CGR. The topic of the CGR is congenital esophageal atresia with or without tracheoesophageal fistula. As you people know that tracheoesophageal fistula with esophageal atresia is a difficult and difficult deformity which involves the two systems. One is the GI system and another is the respiratory system. So there is deformity in the esophagus and sometimes in the trachea. So because of two deformities, there is a their representation and representation in the clinic is very varied. So in this CGR, we will briefly describe about this deformity and brief history with case scenarios, and I will share my experience in SGPGI. If we think of it, the disease was first described almost 270 years back, but the first survival was seen in 1940. That is after a gap of almost 270 years, and that also after multiple surgeries. Next, please. But I thank to this person who described a procedure which enable us to treat these patients very easily, and it is now the one of the most fascinating and sorted out operation for young pediatric surgeon. Now I will call Dr. Pujna to give a brief description about this disorder.
Good morning, everyone. I am in the Department of Pediatric Surgery. I will give a brief introduction about the esophageal atresia and also the management and also what are the cases that we are experiencing encountering in our experience will be discussed in the further presentation. So according to the studies done, it is shown that the incidence of esophageal atresia in Indian subcontinent is more when compared to the Western countries. That is, it is about 12.5 in 1,000 surgical admissions. And it is most common associated with prematurity, and it is also most common with the low birth weight babies, and that is less than 2.5 kilograms. And antenatally, it is most commonly associated with the polyhydramnios. And it is found out that both the sexes are almost equally affected. And also studies have shown that there is a chance of recurrence when the siblings were affected. And also the recurrence chances increases up to almost 4% if a parent is affected. So there are different classifications given in the history for the management and the prognosis of the esophageal atresia. The most historical importance is of the classification given by Vogt in 1929, and also the recent classification given is by the Gross given in 1953, which I will be showing later. So the Vogt classification, he's a radiologist who recognized the types of the anomalies, and so according to his classification, the most common is the type 3B, that is distal tracheoesophageal fistula, where there is a fistulous communication with the distal esophageal pouch and also the trachea. So coming to the Gross classification, there are 5 types described along with the congenital stenosis of the esophagus, and the most common is the esophageal atresia with the distal tracheoesophageal fistula. As shown in the figure here, we can see that there is a fistulous communication with the distal esophagus and the trachea, and the incidence is of about 86%. And next most common is the type A. It is isolated esophageal atresia without TEF. As shown in the picture here, there is no fistulous communication, but there is esophageal atresia, and its incidence is about 5%. And next most common is the type E or the H because of its representation. It's an isolated TEF, and its incidence is about 3%. And as shown in the figure here, there is a fistulous communication with the trachea, but no atresia. So the diagnosis, usually we will have a suspicion when the antenatal scans showed the evidence of polyhydramnios, and usually this can be done from the 18th week scans, and it has the 42% sensitivity and also 52% predictive value. And when the fetus is having absent or the small stomach, and also if there is absence of swallowing in the fetus, then we should have a suspicion of tracheoesophageal fistula with esophageal atresia. And a good sonologist might give a sign that is called pouch sign, also known as anechoic area in the neck, as being shown in the figure here. There will be an anechoic area in the neck region. So postnatally, these children will be having the symptoms of pooling of saliva and the secretions in the mouth, and the baby will be having symptoms of respiratory distress, and also they will be unable to have feeds, and they will be having symptoms of choking on the feeds, and a physician will be unable to pass the stiff NG tube beyond the 10 to 13 centimeters from the nails. So when a newborn comes to us with the complaints of drooling of saliva, that is, and also the pooling of secretions, and with the symptoms of respiratory distress, when we examine the patient, if we see a scaphoid abdomen like this, then our main suspicion will be the pure esophageal atresia. And when the newborn with the suspicion of the esophageal atresia with the distended abdomen like this, then our main suspicion will be the fistulous communication. As the distal fistula is most common, it's our main suspicion. So these patients will be managed mainly medical for the pre-op stabilization, and then the surgical. Surgical is the mainstay, but pre-op stabilization is of utmost importance. So medical management is most important because it plays the role in the stabilization of the patient and includes the resuscitation protocol, that is temperature, airway, breathing, and the circulation control. And I should stress that emergency surgery is seldom done because, as I have said, stabilization should be done first. And also surgery will be done after 12 to 14 hours, as it will take that much time for the stabilization of the patient, and also for the to rule out other anomalies, and also for the management. So these patients should be kept in a propped up position, and these patients should be having the low pressure continuous suctioning from the upper pouch for the secretions. This will be done by the Replogeal tube as shown in here. Here in our department, we will do a makeshift Replogeal tube with the use of two tubes. That is a suction tube and also infant feeding tube. We will insert the low bore tube or the small bore tube inserting into the large bore tube, which helps in the low suction. And we should do all the investigations to rule out the other congenital anomalies like cardiac and the anorectal malformations. And also, with all the suspicion of the tracheoesophageal fistula, we should confirm our diagnosis by the babygram, that is X-ray. So the management, as I said, is mainly surgical, and it is done by the right posterolateral thoracotomy. So when we go by the thoracotomy approach, if the anastomosis is feasible, we will do a primary repair. But when the anastomosis is not feasible, that is if there is a long gap or when the baby is very low birth weight, then in our institution, we will follow that the diversion followed by the substitution later. That is cervical esophagostomy with gastrostomy followed by the substitution procedures. But nowadays in Western countries, they are doing with the delayed primary repair. But in our setup, mostly the patients will be presenting in later stages of life, that is after 2 days or 3 days of the birth. So they will be already deteriorated and with the symptoms of, deteriorated symptoms of respiratory distress. So usually we will proceed with the diversion procedures followed by the substitution procedures later. So I will start with the case. This is a baby of presented on the day 2 of life, delivered by cesarean section with birth weight of 2.5 kgs, with the symptoms of pooling of saliva and the secretions in the mouth, and also the symptoms of respiratory distress with fever. So on examination, there is a nasal flaring and chest retractions. Both are the signs of respiratory distress with abdomen distension. And there on further examination, the respiratory rate is 66 per minute and saturation on the room air is 89%. So with all these findings, our suspicion is of the esophageal atresia only, and so we tried to put the NG tube, which cannot be negotiated, into the stomach. So we proceeded with the X-ray for the confirmation of the diagnosis, where it is shown that there is a coiling of the NG tube in the upper thorax, as it can be seen here marked, and there is a distal stomach bubble, as can be seen here. It indicates that there is a distal fistulous communication. As I said, most common is the type C. So this patient was initially stabilized with the head end up elevated, and also we did the continuous suctioning of the oropharynx with makeshift Replogeal tube, and also we did the chest physiotherapy. But with all the measurements taken, still the respiratory distress had worsened, so we kept the baby on the mechanical ventilatory support with the help of the NICU team. And after the stabilization and all the investigations, and we took the baby for the surgery, that is posterolateral thoracotomy. We kept the baby in the right lateral position with right side up as shown in the figure here. And our approach is mainly extrapleural approach. That is, we go above the level of the pleura and we will try to locate the astragalus vein. Here we located the astragalus vein and we opted to preserve it. Usually, it's a surgeon's choice whether to preserve the astragalus vein or to ligate the astragalus vein. We opted to preserve the astragalus vein. And in the figures shown here, this is the delineated distal fistula with the fistula's communication with the trachea. And in the next picture, it is the upper pouch with the esophageal atresia. As it can be seen here, the gap between the two pouches, that is upper and the lower, the gap is small. So we proceeded with the primary repair. So here in this pictures, we can see that the astragalus vein had been preserved and with the complete esophageal wall anastomosis. Here I should mention that usually all these anastomosis will be done under the tension. So as these are done under the tension, and we will ask the NICU team people who will take care of our post-operative babies for the not to extubate the baby for a minimum period of 72 hours, and also to not to remove the NG tube which was kept transanastomotic. Here in the last picture, we can see the astragalus vein hooked and also the completed esophageal anastomosis. So this baby had the uneventful post-operative recovery, and on post-operative day 1, we did a post-operative X-ray to rule out whether there is any pathological changes in the lung. And as it can be seen here, there are no pneumonia changes in the lung, and baby had recovered well. And baby was started on the NG feeds from post-operative day 3, and we did a dye study on post-operative day 7. This is the dye study. It was dye was given through the oral route, and here we can see that dye had passed into the stomach without any leak. And in this X-ray, we will also see whether if there is any reflux of the dye into the esophagus, and also if we can also see whether the caliber of the lumen is okay or not. This patient was started on the oral feeds from post-operative day 8, and the patient was discharged by day 9. And now, right now, the patient is on the follow-up with no events and no complications. Now I will call on Dr. Pratibha to proceed with the further presentation.
Thank you. Moving on to the next case. We had a 1-day-old male child who was born with cesarean section with a birth weight of 2.3 kg, who had complained with drooling of saliva, labored breathing, and on examination he had tachypnea and tachycardia with labored respiration and chest retractions. Abdomen was distended in this child, and NG tube could not be negotiated in the stomach. This was the X-ray of the child. You can note that there is a coiling of NG in the upper pouch, and also there is air in the stomach, which is indicative of esophageal atresia along with the tracheoesophageal fistula. So this child was intubated and was kept on mechanical ventilation. After day 2 of admission and stabilization, child underwent right posterolateral thoracotomy with ligation of the tracheoesophageal fistula and end-to-end esophageal anastomosis. The gap length between the atretic esophagus ends were around 3 centimeter, and the anastomosis was under mild tension. And the post-operative course was STOMY on this child. Post-op day 1, the endotracheal tube was blocked, and hence the endotracheal tube had to be changed. Post-op day 3, it was noted through the ICD that there was bubbles noted, and also there was leak. There was saliva in the ICD drain. So we had a suspicion of anastomotic leak, for which, as the child started to deteriorate on post-op day 4, we took a decision for diversion of the anastomosis. That is, we got the upper part of the anastomosis was dismantled, and the upper part of the esophagus was brought out in the cervical region as a cervical esophagostomy, and the lower port as a feeding port, lower end as a feeding port. What is the next step in this child? An esophageal replacement. So we will be dealing this esophageal replacement under 3 headings. That is, what are the characteristics of an ideal esophageal substitute? What are the types of esophageal substitutes which are available? And also the routes for the esophageal substitute placement. So coming to characteristics of an ideal esophageal substitute, the substitute must function as an efficient conduit from mouth to stomach to satisfy the nutritional needs of the child. Gastric acid reflux into the conduit must be minimal, and if reflux does occur, the substitute should be able to resistant to the gastric acid. The substitute should not impair respiratory or the cardiac function. The operative technique should be technically unchallenging and adaptable to the small child. The conduit should not produce any external deformity. Most importantly, the conduit must grow with the child and continue to function into the adult life. Then the types of conduit which are available for esophageal replacement are colon, stomach, jejunum. Stomach, it can be used either as an entire stomach as a pull-up, or a gastric tube can be made. So every conduit has its own advantages and its disadvantages. So for example, colon, it gives us an adequate length, but the disadvantage being it has a precarious blood supply and it involves 3 anastomosis, and there is high incidence of leak and stricture. Stomach, as I mentioned earlier, it can be used as an entire stomach can be brought out, like a gastric pull-up can be done, or a reverse gastric tube anastomosis can be done. Excellent blood supply, but it has a long suture line, so there is high incidence of leak and stricture. In our institute, we generally prefer stomach as a conduit. Moving on to the routes for positioning the esophageal substitute, we have the retrosternal route, which is very easy for us to perform the esophageal substitute. But the tracheoesophageal fistula children will be associated with, most of the time associated with cardiac anomalies. So some of the children might undergo cardiac surgeries, during which retrosternal route may not be available for us for the substitution. So in those situations, we use the posterior mediastinal route. So in this child, we did an esophageal replacement with gastric pull-up via the retrosternal route. So this one is the cervical esophagostomy, and this one is the feeding port, the lower end of the esophagus, which was brought out as a feeding port in the abdomen. So first, the position will patient will be placed in supine position with the head turned towards the right side, and an upper midline incision will be placed, and the abdomen will be opened in layers. After opening the abdomen in layers, the dense adhesions with the liver will be released, and the feeding port will be released from all around its adhesions. Followed by that, the most important thing is the release of adhesions from the stomach. So we will have to make sure the blood supply of the stomach is well preserved. So in this scenario, we preserved the right gastric artery was preserved, and the right gastroepiploic artery was also preserved, and the left gastric artery was ligated along with the small gastric artery, short gastric arteries. So we usually perform a drainage procedure, that is a pyloroplasty, and after pyloroplasty, we created a retrosternal plane in the lower end. Then moving on to the cervical region, the cervical esophagostomy was released all around from its adhesions. Then the upper retrosternal tunnel is being made. The complete retrosternal tunneling was completed, and a corrugated drain was placed from the cervical region to the abdominal wound. The upper end of the esophagus is closed, and after closure, the highest part of the fundus will be anchored to the lower end of the corrugated drain, and using railroading method, the stomach was pulled out through the retrosternal plane and was delivered into the cervical wound. After that, the corrugated drain is cut, and in the posterior part of the stomach, a transverse incision is made, and the esophagogastric anastomosis was commenced. Here, we first start with the posterior layer anastomosis, we placed simple sutures, that is interrupted sutures were placed. Great care has to be taken in placing the sutures close to each other so as to prevent post-op leak. After finishing the posterior layer anastomosis, we will be placing a trans-anastomotic drain. Here, a 10 French NG tube was placed. This is to help in decompression of the stomach in the postoperative period and also for the drainage of saliva. After placing that, the anterior layer anastomosis was commenced in similar fashion using 40 PDS. Interrupted sutures were placed. After completion of the anterior layer anastomosis, we went ahead and performed a feeding jejunostomy. After the feeding jejunostomy, the cervical and the abdominal wounds were closed in layers. Moving on to the postoperative course, feeding jejunostomy feeds were started on post-op day 3. Then oral feeds were started on post-op day 7. There was a minor leak present from the cervical wound, which was managed conservatively. Patient was discharged on post-op day 12, and at present, 12 months follow-up, patient is asymptomatic, there is no leak, he is accepting feeds well and with a good weight gain. Moving on to the third case scenario, this child was presented at an outside hospital with respiratory distress complaints and drooling of saliva, and he was investigated in the outside hospital in the form of X-rays and all the routine investigations, and X-ray showed coiling of NG in the upper pouch. But the most important thing to note over here is there is no gas in the stomach, so which is suggestive of an esophageal atresia, but there's no fistulous communication. It is a pure esophageal atresia. So for which in the newborn period, child underwent a cervical esophagostomy and a gastrostomy. Child was referred to us at 7 months of age, and at age 1 year with a weight of 10 kg, child underwent esophageal replacement with reverse peristaltic gastric tube via the posterior mediastinal route. We preferred the posterior mediastinal route in this child because child had VST and had underwent cardiac surgery, and as I mentioned earlier, there was a retrosternal route was not available for us. So here the same patient in supine position, upper midline incision, and then the mobilization of the gastrostomy is being made. That is, it is released of all its adhesions, the attachments all around, and using an energy device, and great care has to be taken to not injure the stomach or its vascularity. So after the mobilization, the stomach mobilization was commenced by releasing its attachments, that is the adhesions which were present with the liver, and also the attachments and the adhesions which were present with the colon. Next step for us is to perform the make the gastric tube. So for which around 3 centimeter proximal to the antral region, along the greater curvature of the stomach, the gastric tube will be made. And the most important thing is this is based on the left gastroepiploic vessel, so which is indicated by the number 7 here. So after ligating the right gastroepiploic vessel and preserving the left gastroepiploic vessel, we make a gastrostomy here at 3 centimeter proximal to the antral region, and a Hegas dilator will be placed along the greater curvature of the stomach, which will be used as a guide, a bougie, and then using a linear stapler, and it will be fired along the greater curvature of the stomach. And here, as you can see, that the reverse gastric tube is been made and which will be flipped upside. So in this patient, you can see the suture line over here, the stapler, and also over here. So this is a reverse gastric tube, and this upper end of the esophagus will be resected, it will be divided. And then like the previous procedure, through the posterior mediastinal route using railroading, this reverse gastric tube will be delivered in the cervical region, and the esophagogastric anastomosis was performed, and along with the feeding jejunostomy. Postoperatively, FJ feeds were started on post-op day 4, but the child had leak from the cervical region, and child was initially tolerating feeds, but eventually the child could not tolerate oral feeds. So on further investigating the child in the form of endoscopy, it was revealed that there was a stricture noted. So hence, after 6 months, we took a decision to re-explore the cervical region. So on re-exploration, the cervical anastomosis region, there was a stricture segment noted, and that strictured segment was resected, and an anastomosis, re-anastomosis was done. Right now, child is tolerating the feeds well, and he's been followed up in the ped gastro department for endoscopy, and in case if dilation is required. So moving on to a meta-analysis paper here, for all the long gap esophageal atresia, the different conduits were compared. So it is noted here that the gastric pull-up and the colon interposition both appear comparable with regards to post-op mortality, anastomotic complications, and graft loss. But in the long term, the gastric pull-up, it is yes associated with higher respiratory morbidity, but it had fewer gastrointestinal complications when compared to the colonic interposition. So now I would like to invite Dr. Anju for further case presentation.
So proceeding with the next case, a 6-month-old male child with a weight of 4.5 kg presented to us with a complaint of coughing while feeding with history of recurrent attacks of pneumonia. On examination, along with tachypnea and tachycardia, mild chest retractions were found. Abdomen was sought without any distension. Anal opening was normal, and NG could be negotiated in the stomach. So suspicion of H-type fistula was made, and the child was started on NG feed, which he tolerated well. So for the suspicion of H-type fistula, a CCT chest was done. And the CCT showed a fistula, tracheoesophageal fistula, which can be seen by the arrow here. Now the child has been planned for bronchoscopy, and the bronchoscopy showed us as gross H-type fistula. So child has been planned for operative management, and the ligation and division of tracheoesophageal fistula was done along with the repair of both esophageal and tracheal end. Child did well in the post-operative period and also doing fine in the follow-up. So coming to our experience, in the last 7 years, a total of 38 patients were operated, out of which 33 are esophageal atresia and tracheoesophageal fistula, 3 patients of pure atresia, and 2 patients were of isolated TEF. So if we go by classification wise, we had 86.8% patient in type C, 8% patient in type A, and 5.2% patient in the type H, which corresponds to the data given in the literature. As a tracheoesophageal fistula is a complex anomaly and associated with various congenital anomalies. The cardiac anomalies are the most common anomalies associated with them, and these cardiac anomalies are also involved in few prognostic classifications. After the cardiac anomaly, it is associated with various genitourinary anorectal malformation and other anomalies. In our experience, we found a total of 23 anomalies in 14 patients. These are the pictures showing a hand anomaly, cleft palate, right lumbar mass, anorectal malformation, and the X-ray showing vertebral anomaly. So if we compare our associated anomaly data with the various Indian institute, we have comparable cardiac and skeletal anomalies, but rest of the anomalies we found were less. And on comparing our data with the global data, we have comparable cardiac anomaly, that is of 31.5%, with rest of the anomalies we found were less, with a total cardiac total anomalies of 37%. So as any surgery is bound to have some complications, the TEF surgery is also bound to have some complications, out of which the gastroesophageal reflux has been documented the most common complication in the literature. But in our series, we found the post-operative lung infection was the most common complication with a 63.1%. Here in the X-ray, we can see the post-operative lung infection showing the hazy field in the lung field. And the least common infection complication we found was the gastroesophageal reflux with the percentage of 5.2%. Here, these are the post-operative X-rays showing the gastroesophageal reflux. Second most common complication we found were the anastomotic stricture with the percentage of 31.6. Now this is the dye study showing the anastomotic stricture. And third most common complication was anastomotic leak with the percentage of 26.3%. And here is the dye study showing the leak in the of the contrast in the mediastinum suggestive of leak. So if we compare our data with the various Indian institute, the anastomotic leak is of the same percentage that is comparable, that is 26.3%, and anastomotic stricture is also comparable, that is of 31.6%. But we had a bit higher post-operative lung infection with the percentage of 63.1. And similarly, comparing the global data, we have comparable anastomotic leak 26.3%, comparable stricture rate, but having a high percentage of post-operative lung infection, though it was not documented in most of the studies. So now if we go by gap length, there are 4 groups have been made. Group A is the ultra long, in which the distance between two esophageal pouches more than 3.5 centimeter. Group B is the long gap, with the distance between two pouches is between 2 to 3.5 centimeter. Group C is the intermediate gap, with the length distance between two pouches is between 1 to 2 centimeter. And group D is the short gap, with distance between the two esophageal pouches is less than 1 centimeter. So on comparing by chi-square trend, the odds ratio of having risk of anastomotic leak in group A is 34 times higher than group D. And similarly for risk of stricture, group A has 21.3 times higher risk of stricture as compared to group D. So now comparing the anastomotic leak between various groups, between various Indian institute, we have comparable leak rate in the long gap, but lower leak rate in the intermediate gap with the overall comparable leak rate. On comparing leak rate in the various global data, we have comparable leak rate in long gap and with lower leak rate in the intermediate gap with the comparable overall leak rate of 26.3%. So many prognostic classifications has been made, which include Waterston's, Montreal, Spitz, and revised Okamoto. The Waterston prognostic classification has 3 groups: Group A, B, and C. In the Group A, the baby has been birth weight of more than 2.5 kg without any cardiac anomaly or pneumonia, with a survival rate of 95%. Group B, birth weight between 2 to 2.5 kg without any anomaly, or birth weight more than 2.5 kg with moderate pneumonia or congenital anomaly, with survival rate of 58%. And group C, birth weight less than 2 kg or any birth weight with severe pneumonia or severe congenital anomaly, with survival rate of 6%. Other classification uses Okamoto classification, in which 4 classes has been made, class 1 to 4, which is based on birth weight and cardiac anomaly, with a maximum survival rate of 100% and minimum survival rate of 17%. So coming to our outcome, out of operated 38 patients, 35 patients have been survived with a percentage of 92.1%, and 3 patients were died with a mortality of 7.9%. So as per Waterston criteria, we had 12 patients in class A, 12 patients in class B, and 14 patients in class C. So now comparing the survival rate as per Waterston's prognostic classification, we had comparable survival in class A and class B, that is 91.9% and 90.9% respectively, but a higher percentage of survival in class C, that is 92.3%, with comparable overall survival rate of 92.1%. And comparing to the global data, we have comparable outcome in class A, B, and C, with overall comparable survival rate, that is of 92.1%. So the take-home message is that esophageal atresia is a complex congenital anomaly with a spectrum. It is one of the most important differential diagnosis for surgical cause of respiratory distress in newborn. Though the diagnosis is simple and made clinically, it is confirmed radiologically, and we have to rule out other congenital anomalies also. Treatment is always surgical and depend on the type and the presentation of the baby. Though the treatment is surgical only, but it is not a dire emergency, and we have to optimize the patient first. Open repair is the gold standard, but the thoracoscopic repair is being also done in the stable and good weight baby. Native esophagus is the best option, but if we have to go for replacement, we usually go for gastric pull-up and reverse gastric tube. So the esophageal replacement is a complex undertaking and should be performed in the specialized center having a multidisciplinary team. So in the last, we want to acknowledge our anesthesia team who help us in operating these patients at any time in the day or night when they are stable. We are also blessed with having a great neonatology and CCM team who help us in managing these patients perioperatively. We are also thankful to pediatric gastrology, intervention radiology, and cardiology team in managing the postoperative complications in the patients. And we are also thankful to our beloved patients, OT team, and ward staff for managing and operating these patients. Thank you.